Welcome, everybody. My name is Zach Solar. I'm a professor of Rhinology at the Medical University of South Carolina. And this talk is about chronic rhinosinusitis. And we're going to focus on subtypes and endotypes. And just as a sort of a quick aside, this is a topic that's rapidly changing. So there's always new evidence. And it's my expectation that as the months and years go by, the things that I talk about are probably going to be outdated. So just as a note, this talk was put together in February of 2022. Just for disclosures, I'm a consultant for Novartis, GSK, Lyra, Optinose, and Sinusonic. And we're not going to talk about any of those things specifically, but that's just worth keeping in mind. So as an outline, these are the things we're going to talk about. First is just the idea of heterogeneity within chronic sinusitis. Touch on current clinical subtypes, the concept of phenotype, the idea of endotype, and then focus on endotyping in sinusitis specifically, how that might impact personalized treatment, and then we'll just have conclusions and key points. So the first point I want to bring up is just the idea that chronic sinusitis is a heterogeneous disease with a shared diagnostic criteria. So in other words, it's an umbrella term. It's sort of a general diagnosis, but it encompasses a lot of different subtypes. And for you listening in 2022, that's not a new idea. It's an idea that's commonly talked about, but it really wasn't a commonly accepted thing if we go back 20 or 30 years, where people just sort of considered all sinusitis to be the same, or at least all of it to be just sort of a problem with plumbing. So we focus on the diagnostic criteria. I think most people are familiar. In order to make this diagnosis, you have to have 12 weeks of symptoms. Those symptoms have to have 2 out of the 4 cardinal symptoms of congestion, drainage, pain and pressure, and decreased smell. So if you have 2 of those symptoms for more than 12 weeks, and then you have some type of evidence of inflammation, you look in the nose, you see inflammation, you see polyps, something different on the CT, then by criteria, you have chronic sinusitis. So if we use that sort of generalized diagnostic criteria, or at least we focus on the symptoms, you can see a pretty significant group of the population has that. So this is a study out of Europe, estimating 11% of the population, ranging from 7 to 27%, depending on what country or city that you're looking at, will at least have the symptoms of sinusitis. Similar study out of China estimates 8%, ranging from 5 to maybe up to 10%, again, symptoms only. And in the United States, some studies suggest anywhere from 10 to 15%, but upwards of 1% of all clinic visits for symptoms associated with chronic sinusitis. But if we look at that, a large percent of the population has this, but they're very different when we actually look at the specifics of one patient does not all look alike. So here I just sort of grabbed CT scan pictures of patients that I've seen in the last just a couple of weeks. And if you look at the upper left part of the screen, this patient is very different than what you see on the upper right part of the screen here. So this is not just a severity of disease problem, but a completely different disease process, both of which are sinusitis though. So, again, this is one of those ideas where you know it when you see it, but it's all sort of one overall grouping. So I kind of like to use this picture as an example of that. Everybody would look at this picture and know, hey, this is just a picture of dogs, right? But how do we know these are all dogs? We've just sort of come to understand that these are all dogs, even though this Great Dane here at the upper left is huge and very different than the Chihuahua at the bottom here, but they're all dogs, right? Of course, we know that you can subtype these dogs into different breeds of boxers and whippets or something like that. And we know that people can look and immediately identify that this Doberman is very different than the pug just by looking at them, even though they're all dogs. Of course, with more information, with genetics, you can really hone down on the differences here and start to see which ones might be more similar than the others, how they are categorized, etc. I think there's a loose parallel here to sinusitis as well. So let's talk a little bit about how do we do that? How do we go from a very generic diagnostic criteria to try to subtyping these patients? So point number 2 here is that I would argue that most chronic sinusitis patients undergoing surgery have a known phenotype. So I like to take this picture. This is sort of, Mendel's pea plants. This is elementary or I guess middle school genetics. And you can see here different phenotypes that these pea plants have, right? So the shape of the pea might be round, color is green versus yellow, or the pea pod might have a different shape, the flower may have a different color. These are all phenotypes. And of course, early on, nobody had any idea of genetics, but eventually you can go back and sort of start to understand what underlying genetics then result in different phenotypes. So let's talk about phenotype. So what exactly is phenotype? Well, it's the classification of a disease based on a group of observations. So something we can look at, perhaps its symptoms, maybe even a lab value. These are things that are observable. So an example, of course, we all know is nasal polyps. So we've long classified sinusitis into with or without nasal polyps. This is just a phenotype. It's a phenotypic classification. I'd argue also that there's other ways of phenotyping patients. So something like allergic fungal sinusitis has a pretty classic phenotype, an observable set of traits, and we'll talk about that. Things like fungus ball, donogenic, again, I would say, have a very classic phenotype. So classic ways of doing that, again, the presence or absence of polyps. Within the polyp group, I would argue you can subtype based on phenotype. Allergic fungal sinusitis has a very specific phenotype. Bent-Kuhn criteria, we'll talk about. Aspirin exacerbated respiratory disease is a phenotype in and of itself. So they have asthma. They have a classic reaction to aspirin or NSAIDs. They have polyps visible on endoscopy. So that is a phenotype way of classifying. Of course, AERD is an endotype as well, which we'll talk about. Are you cystic fibrosis patients have a very classic phenotype as well. Certain type of bacteria they're more likely to have. A presence of sinuses that tend to be hypoplastic in nature. In the non-polyp group, again, fungus ball, donogenic, have very classic kind of phenotypes. So I just, as a thought experiment, I wanted to take my last 100 surgeries and just sort of break it down to say, could I classify them specifically? So one easy way of phenotyping doing that is just based on polyps. So in my own practice, I looked at the last 100 cases, 58% of the 58 of them were not polyp and 42% had polyps. So if we take the non-polyp group, I said, could I subclassify them just based on phenotype? And 28% were fungus balls. I live in the South, there's a lot of fungus around here. 17% were tooth related or donogenic. 17% were obstructive. I'm using this term to talk about usually revision surgeries where somebody didn't open the sinus the way it should have been. They have recirculation, something like that. And then 38% of the time, I had no idea. I know they didn't have polyps, but I couldn't really give you any other discerning features about them. I just don't know really much else about those patients just looking at them. What about the polyp group? So 34% were allergic fungal sinusitis. Again, that's probably part of my referral practice in the South. As a tertiary practice, I get sent these patients. 14% were cystic fibrosis, 14% had AERD, 19% had asthma or systemic eosinophilia of some point, so something pushing you to sort of that type 2 type picture. And then 19% really had nothing special about them, nothing that I could sort of subclassify those patients. So phenotypic classification, this is what we've been doing, for decades now. So in my last 100 cases, 38% of my non-polyp group, I couldn't really further phenotype. 20% or so of my polyp group, I could not further phenotype. And, obviously out in your practice and what you see is going to vary based on mine, right? But I think the point remains that if you were to really try to phenotype your patients, you can actually do a reasonably good job of separating patients into subtypes just based on basic phenotypes. Next, I would argue that based on phenotypes alone, we can often infer the endotype and mechanism of disease of what caused that patient's sinus. So before we get too far, we have to sort of define endotype. Now, I want to sort of acknowledge that people use the term endotype in different ways. And I even do it sometimes talking out of both ways of my mouth. But one way of defining this that I think a lot of people use is they talk about biomarkers. So they're talking about looking at biomarkers like cytokines and saying, okay, we're going to then classify patients based on these biomarkers, and then they're calling that endotype. And that's not a wrong way of doing it, and I do that as well. But I'd argue one way of thinking about endotype is a subset of disease that's based on underlying molecular mechanism specifically. So you're saying, what is the pathophysiology? What's the cause of that? And that's the endotype. So not just what it looks like, the phenotype, but the actual underlying cause. So not just a set of biomarkers, although I would argue that biomarkers are often used to describe the endotype. It's not just the biomarkers, but it's what the biomarkers are reflecting. They're reflecting an actual mechanism of disease. So if we go back to sort of this process, this fungus ball, I would argue that the phenotype, we can infer the mechanism. Okay, there's fungus that got trapped there. It's causing irritation, and that's the process of sinusitis. Same thing here. This infected tooth resulted in chronic infection. That chronic infection leads to a specific type of inflammation. That's the mechanism involved. Same here with this obstructive. This is the fact that the natural ostium of the sinus is not open. The mucus is moving in a coordinated fashion to that one opening. It's then falling back into the natural thing. And that sort of obstructive recirculation phenomenon is what's the cause. Of course, this is one that's unknown. I have no idea what this underlying mechanism of why this particular patient has sinusitis. Here's an AFRS patient. I would argue that based just on this picture, we know this patient has type 1 hypersensitivity to mold that's in their environment. There's fungus that's trapped in here that's inducing type 2 inflammatory cytokines, and that is the underlying mechanism of disease. I don't need necessarily a biomarker profile of the mucus or the tissue to know that. We know that based on this phenotype. Same thing with AERD. We know, once we know that somebody fits the AERD phenotype, we then know based on research of basic science, et cetera, research of the underlying pathways. There's much more smarter people than me that can talk about the arachidonic acid pathways, et cetera, that are often these type of patients. Cystic fibrosis, again, this is one where there is a phenotype. Of course, we know there's a very classic genotype, and we understand the CFTR gene and what's going on in this patient and what leads to chronic sinusitis. But of course, this patient I showed you, this is the one who we don't know. It's unknown. I don't have any sort of phenotypic features that discriminate this patient. I have really no idea why they have sinusitis or how to target their treatments. So again, just putting this into sort of a table, let's start something simple like odontogenic. The mechanism is a periapical abscess with infection. And then the endotype profile is this patients are going to have microstrep or anaerobic infection leading to neutrophilic type 1 inflammation, and that's the underlying. Very different than the AFRS patient who has a type 1 fungal hypersensitivity. And if we were to then do tissue biopsies or run a cytokine profile, we would see very significant elevations in type 2 inflammatory infiltrate of how to treat that. So again, based on the phenotypes, I think we can infer endotype based on a lot of research that's been done that can guide treatments. So point 4 here, sinus surgery treatments and outcomes often differ by disease subtype. So what does that mean? That means sometimes I have patients who sit in my office and they say, Doc, I'm not sure about surgery. My friend had this and they didn't really get any better. I'll have other patients come in and say, Doc, I want surgery. My friend had it, they did great. And I say, look, you guys have two completely different things and your outcomes to treatment may look very different. So is that true? And I would argue we can infer a lot of outcomes based on things. So first off, there are conditions where sinus surgery is going to be what I call curative. So something like a fungus ball, odontogenic sinus, these obstructive recirculation ones, 99% success, right? Small amount may have a technical failure, but if you open the sinus, you take the fungus ball out, these patients are going to do great. Same with odontogenic. What about the rest of the CRS patients? What about sort of just the other patients that we take? What kind of outcomes are they going to do? So I like to show this study. This is a slide from a study that Tim Smith and I did where we looked at quality of life outcomes. We followed patients, up to a year and a half after surgery. And you can see, sure enough, there's significant improvements in their RSDI score, which is a quality of life score. These are much greater than the minimal clinically important difference. So we can say, hey, yeah, on average, sinus surgery really helps all these patients. But the secret here, and you know this if you operate on patients, is that this is what the real data looks like. So this is average data. Here is individual data. And you can see people are all over the place, right? There's a lot of people who do really well, but hey, look at this patient. They actually did worse. Some patients who aren't significantly different than over time. So you ask the question, what accounts for this variability? Is it surgical technique? Are we just doing bad surgery on a few people? Is it postoperative medical care? We're just not giving them the right medications. Is it patient compliance? They're just not taking it. Is there phenotypic differences here that can allow us to account for this variability? Or endotype the holy grail? That once we know their endotypes, we'll then be able to figure out why some patients do better and some don't. So here's a systematic review looking at SNOT-22 outcomes across a large group of studies. And that had some phenotype information. And I would argue there typically are not huge differences by phenotype. So if you have a patient with polyps and groups without polyps, they don't really tend to do that much different after surgery. They all do reasonably good. Are there other outcomes that we can look at? What about revision surgical rate? So here's another meta-analysis that looked at 45 studies, 34,000 patients undergoing surgery for polyps. And they were looking at revision rate, like how often you need to revise that surgery. It's about 18, 19% of the time, and it ranges across studies. But one thing you'll see is that if you look at subtypes like the AERD subtype, their revision rate is significantly higher, so 27% versus the average of 18%. Another is AFRS. So if you can identify that subtype, they're more likely to have revision surgery than the group that doesn't. And again, asthma is that one. So the revision surgical rate, 22% if you have asthma versus only 8% if you do. So this is suggesting that understanding these subtypes can actually tell you about treatment outcomes and predict that. So point 5 here is endotyping is necessary for the group of patients who don't otherwise have classifying characteristics. So, I showed you here these unknown patients, up to 30% or so, where even though we have information about their polyp status, I don't otherwise have any idea of what's going on. And I would argue these are the patients that endotyping, meaning biomarkers to understand their underlying pathophysiology, would really help us, because it would then tell us, okay, what type of targeted treatment might we do? How can we guide the treatment? And then how do we predict outcome response? So going back to those sort of crude things that I showed you, in my own personal practice, there's about a third of my patients that I have no idea. I'm flying blind. I mean, I know if they have polyps or not, but I don't know anything about the actual mechanism of what's causing their disease. And then I don't know how to best tailor treatment. And a lot of times this is the trial and error patients, right? Where we just try something and we see how it goes. So let's talk a little bit about endotyping specifically. So what kind of evidence is there out there? So this is probably the first study that looked at this, or at least I would say in the modern era, the most popular study that came. And this came out of Europe. So Thomason et al. And Klaus Baukert's group. And they took patients who were undergoing surgery, they took biopsies, and then they looked at a number of different biomarkers. You can see a lot of inflammatory biomarkers, including things like IL-5, TNF-alpha, IgE levels. And they used those, and they used statistical clustering algorithms to sort of cluster and figure out, can we classify these patients into groups just based on their biomarkers? And this is what you saw. You see they clustered into 10 different groups based on these cytokines that they looked at. They had kind of an IL-5 low group, an IL-5 high group, and you can start to see some differences. And if you kind of go back to phenotype here, you can see this is the group that had more likely to be without polyps and not to have asthma, and they were low in IL-5 and low in some of these type 2 inflammatory products. The group that was polyp, the group that had asthma, again, had higher IL-5, more likely to have staph superantigen, IgE, eosinophilic cationic protein, etc. So this is sort of proof of concept that you can know nothing about a patient except for these biomarkers and start to cluster them in meaningful ways. Here's a more recent study that I was involved with, where We actually put sponges in the nose. We collected mucus. We ran sort of this cytokine profile that you can see here and said, okay, based purely on cytokines in the mucus of somebody's nasal cavity and sinuses, can you cluster patients? And this kind of just shows how those inflammatory profiles cluster. And in this study, we also generated 10 clusters. And this sort of shows which cytokines belong to what cluster. And just want to point out, like, say, for example, cluster 2 here in red, these are cytokines that are upregulated significantly. And you can see in this cluster 2 patient, very high levels of IL-4, IL-5, IL-13, and IgE as well. So this is a very high type 2 inflammatory cluster. When you look at cluster 6 here, these are patients that have elevations in things like IL-6, IL-8, TNF alpha as well. So this is sort of more of a type 1 inflammatory profile. So you can sort of see how you may then say, all right, here's a group, cluster 2, that we would really want to target type 2 inflammation. And here's a group, cluster 6, that we might want to target type 1 inflammation. And then there's other clusters that are kind of mixed across this. So the recent ICAR document in 2021 summarized the studies that have tried to endotype this. So this begins in 2016 with Thomason. There's a Divicar study in 2017, Lau in 2018, Justin Turner in 2018, and Hoggart in 2018 as well. So this sort of goes through different biomarkers that people use, different clustering algorithms to sort of try to endotype this patient. So again, this is going to be useful for the patient that has no real phenotypic characteristics to guide us. Can the endotype guide us? So let's talk about personalized treatment based on subtypes. Does this exist? And I would argue that we're already doing this, and you're probably already doing this in your practice. So as an example, if you see this patient and you look at this CT scan, you say, okay, I'm highly suspicious this is a fungus ball. So we know this is going to need surgery. All the medicine in the world is not going to fix this patient. A biologic medicine is not going to fix them. An antibiotic's not going to fix them. They need surgery. It probably doesn't matter how big you make this. You just need to get this stuff out. There may be an overlying infection treated with antibiotics, but essentially this is a curative patient. You can tell this patient you're going to highly likely to do great. What about this? You see this patient, they have sinusitis, right? But you look, you see this periapical abscess. Again, you can infer what's going on in this patient. You understand the mechanism. You say, okay, definitive treatment is going to require treating that tooth. They need a root canal, possibly an extraction. Your dentist is going to tell you that. There's likely to be overlying infection, microstrep, perhaps an anaerobic infection. You're going to need to treat that. And then if none of that works, you're going to do surgery, widely open this, flush it all out, and they're going to do great. So the highly chance that surgery is going to be curative in this patient. This is not going to be a long-term problem, most likely. Same thing with this obstructive. We know the pathophysiology here. This is failure to open the natural os. You open that up, put on some saltwater rinses. This patient's going to do great. They're going to be happy. You're going to fix their problem, most likely. What about this patient? This is an AFRS patient. Again, we are already doing targeted treatment for this patient. We're going to do complete sinus surgery. We're going to create as large of openings as we possibly can, maybe extended procedures, maybe a low-throat procedure, or maybe they need a medial maxillectomy, maybe in a revision case. But anti-inflammatory treatments are going to be the mainstay to control this. Oral corticosteroids followed by long-term topical corticosteroids to keep that inflammation under control. We know these patients have comorbid allergies, so treating that allergy is going to be important as well. And then maybe targeted medications in the future. So we mentioned how this is likely a type 2 inflammatory disease. We have type 2 biologics. Although importantly, patients like this were excluded from the initial clinical trials. So there's actually active clinical trials looking to see whether these type 2 biologics are going to be active. I suspect they probably will, and that might be something that we target in the future. What about AERD? Again, oral corticosteroids being an important, followed by long-term topical corticosteroids. If surgery is necessary, large opening surgery is going to be important, possibly extended procedures. These are times where, particularly in a revision case, a low-throat procedure may be useful. Aggressively treating the middle turbinates might be important. And then aspirin desensitization therapy would make sense in this patient where it would absolutely not make sense in other patients. And then type 2 biologics, we know from the clinical trials, target this very well and are going to be important. What about CF? Again, how we treat a patient with CF is going to look very different. Culture-directed systemic and or topical antibiotic therapy is going to be important because we know chronic infection is an important part of this process. Things like MRSA and Pseudomonas, we need to know what's going on, how to treat it. Topical corticosteroids and saline rinses are important parts of the armamentarium. Complete sinus surgery, often with large openings like medial maxillectomies, are important to help control because we know that the cilia just don't work because there's thick dehydrated mucus. And of course, based on the genetics, personalized targeted treatments have been developed, including CFTR modulator therapies like Trikafta, which target the actual underlying endotype or mechanism of disease. So again, it's a subtype that we're treating very different once we know. And again, here's an asthma eosinophilic patient, again, which will be treated in a very specific way. What about these unknown patients? So I said 30% of the time, we don't know. We can't currently classify them. I would argue these are the patients where right now we have non-specific treatments, right? So regardless of what's causing this, oral and topical steroids likely help, right? Because they're non-specific. Saline rinses likely help. Culture-directed antibiotics, if there's an infection, likely is going to help. And then sinus surgery, we know, is likely going to help. But can we get better than that? Can we target personalized treatment? Well, to do that, we're going to have to know the endotype. So these are the patients where in the future, hopefully we can move from research stuff to where we're actually taking either mucosal samples or mucus samples or figuring out the endotype by the biomarker profile, and then that's opening up targeted treatments. It tells us, okay, if we are doing surgery, how big do we need to do it? Do we need large hole surgery, small hole surgery? What about macrolide therapy? If it's a type 1 IL-8, TNF-alpha, macrolide therapy might make sense. If we see a type 2 inflammatory profile, perhaps a type 2 biologic is going to make sense. And we're not going to know how to do that until we endotype that patient. For the CRS with polyp patient, again, non-specific treatments like oral and topical steroids can be helpful, sinus surgery as well. But what about specific treatments? Again, we won't know until we target that patient. We know there's a group of polyp patients that have type 1 inflammation or a mixed inflammation. They're not going to do well at all on a type 2 biologic like Dupixent or dupilumab. Where there's other patients who in fact do have type 2 inflammation and may do very well. And then there's also the question of which type 2 biologic. So even if they have type 2 inflammation, it's highly likely that we are going to be able to figure out, hopefully in the future, which of these medicines to best target. All right, so I want to finish kind of with point 6, which is to say, expect more and more targeted treatments as our understanding of CRS endotypes improves. So as our understanding of AFRS on a basic science molecular levels improves, we're going to be better able to target it, and then we can develop targeted medications to that condition. So the expectation is that 10 and 20 years from now, as we understand more and more, we'll develop more and more targeted treatments, and then we'll figure out how to best deploy those targeted treatments. So as a conclusion, I think we can all agree that chronic sinusitis is a heterogeneous disease. Although millions and millions of people worldwide have this, each person likely has a different type subtype. I would argue that most CRS patients undergoing CRS have some type of phenotype that you can infer by looking at them, at least probably about 2/3. And that based on phenotype alone, we can infer endotype and mechanism of disease based on current understanding of those phenotypes. The treatment outcomes really do differ by disease subtype. So understanding those subtypes are important. And I think endotyping is going to be really important for those patients who don't otherwise have classifying characteristics. And we can expect more and more targeted treatments as our understanding of CRS endotypes improves and as subtypes become even more subtype. So maybe AERD is not just one disease, but it's multiple subtypes. And as we understand them, we can target treatments even better. I included some suggested readings here. So if this is a topic that interests you and you want to dive in, this is where I would start. These are the original sort of basic science studies that looked at this. And the ICAR document has a nice section on endotyping as well. So I appreciate everybody's attention. And again, this was February of 2022. So if you're looking at this, you're listening to this multiple years into the future, take everything I say with a grain of salt. Thank you.